Oh my goodness. A lot of friendly faces. Okay. Well, I can see a big long list of people here, so we might as well get going. So, for formal welcome, hello everybody, welcome. Tonight, what I'd like to do for you is maybe give you just a little bit of an insight into some stuff, some questions that I get asked all the time about office organization, and some answers that I've put together over time for you guys. We have obviously a bunch of people from Progressive here tonight to help you as well. So a couple of things, I won't introduce everybody, but there's a whole host of Progressive people here tonight that can help you on the business side and the seminar side, if you're just considering maybe taking some seminars from Progressive. So any questions that you have for me, please go ahead and put in the chat, and at the end of this webinar, I'll take some time and go through every question that's in the chat regarding the webinar. But also, if you have any questions for the staff at POS regarding seminar schedules or cost of seminars or how you get started or anything, go ahead and stick those in the chat as well. And someone from Progressive will get back to you this evening. They'll start talking to you kind of behind the scenes if you'd like. And then a couple of kind of housekeeping things. In order to get your CE credits, they need to know who you are. So if you could, whatever device you are listening to this on, if you could put your name there so that they can see who it is, so that they can get you on the list to give you the CE credits. Or you can tell them via chat, if you're listening on your daughter's iPhone, this evening or something like that, you can tell them who you are so that they can get you your CE credits. Okay. I'm going to send you this file that you guys are going to see right now in PDF form, so you don't have to take a bunch of notes if you don't want to. So every one of these slides I will send you, and then individually I'll also put in there a lot of the reference files that you'll kind of see in here as well, and I'll include those in a big zip file, and I'll send them to Progressive, and then anyone that's on the list that's watching this evening, they will send those to. So, and if for some reason you're left off and you don't get that, then contact them or contact me, and we'll make sure that you get those. Okay. And then I guess the last thing is just make sure that on your end that you're muted, so that we don't have a lot of background noise as far as people talking in the background, and that would be a tremendous help. Right. So this little presentation right here is just really about 60 slides, and I just put together some information on office organization, and not anything to do with mechanics, not anything to do with the small stream software, just a few answers to a few questions that I've gotten over time, over the years, and how I have actually dealt with them in my office. The way that I'm going to show you how to do certain things is not the only way. I'll kind of point that out to you guys as we're going through, but it's a way that has worked for me. And some of these things I think are really important. Some of them, obviously, depending on your practice style, your office, how big it is, how small it is, will change. But for me, I was always solo. I never had a partner or an associate. 5 operatories. I worked out of 3 operatories. I had 2 hygienists. The 2 hygienists worked out of the other 2. And usually I had, back when I was younger and wanted to work harder, I had 3 assistants. Usually I have 2 assistants. And right now, I had actually sold my office about a year ago, so I no longer do restorative, like I was talking to my friend Fawaz there. And I am only doing just ortho Mondays and Tuesdays in the office that I sold, the same office that I sold it to a friend of mine. Right? So that's kind of the perspective that I'm coming from right now. All right, so let's get started. I guess the first slide that I would like to show you, Actually, let me back up a little bit. You're going to see a couple of things on these slides that are going to make reference to a different webinar. And I'll talk to you a little bit about that at the very, very end. So don't worry about that right now. So if you see any references to another webinar or another list of things, don't worry about that for now. For instance, this slide right here is based on this webinar, but it's just a little part of kind of a larger one that I have made for a 2-day seminar, right? So what I would like to start with is what I call my office organization checklist. So really, no matter if you are already doing ortho, if you're already doing ortho with Progressive, if you're already doing ortho with just you and are thinking about joining Progressive, or if you're just thinking about adding ortho to your office, this is basically the starting checklist that you need to go through in order to get started. I show this in the beginning of any course that I do so that you can get an idea of all of the things that you have to do initially over and above just studying the orthodontics themselves and kind of learning the techniques and learning actually how to do ortho. What you don't know when you decide to add an ortho department to your office is that the ortho and the actual mechanics of doing it are one thing. Obviously, you have to learn how to do the orthodontics. The seminars will teach you how to do the orthodontics from A to Z. But behind the scenes there's a lot of organization that has to go into it behind the scenes to make things run smoothly so that you can be efficient, so that you can actually be productive at the ortho. You don't want to add ortho to your office and be so inefficient, or maybe you could say slow at it, that it takes away from some of the other stuff that you're already doing. We don't want you to do that. We don't want you to, add ortho and then find that, you can't do as much restorative because you're so inefficient at, doing ortho. We don't want you to do that. What we want you to do is add ortho to the office and be efficient at it, be very productive at it, and then also do all of the other things that you're already doing. So this office organization checklist is something that I made that would start you in the right direction. So let me go down this list, and I'll just give you a kind of a brief reason for each one of these bullet points in this thing and how they would kind of fit into, getting you organized in the beginning. So the first one says initial meeting with the entire staff, including your hygienist. The reason why I put that here is because your staff, even though you're taking these seminars, your staff has no idea what you are. Basically, they have no idea what you are doing, right? They know that you're attending a seminar. They might know that the seminar is as inclusive as it is. They might understand that, you are going to be doing ortho just like ortho is done in an orthodontist office, but maybe not. So you need to sit down with your entire staff and really introduce the fact that you're going to be doing comprehensive ortho, not just a little ortho here and a little ortho there, but comprehensive orthodontics. And you're going to be taking the equivalent of a 2-year postgraduate program in ortho. You're going to get the equivalent education of really a 2-year postgrad program by taking the ortho series. So what you really need to do is describe the seminars and the length of the program, what you're going to be learning, and impress that, this is something that is going to be a big, hopefully, a big part of your office and a very, very productive part of your office. Okay? And then the third little sub point there is consider sending the staff to POS assistance 3-day course. One of the things that will slow you down a little bit is not that you won't be able to do the things that you learn in class. It's that all the people that are around you won't necessarily know how to do their part. So Progressive has an assistance course that you can send your staff to, and you can also go as well. And they will teach your staff all the necessary skills so that they can really help you be as productive as possible. And you don't really know how important that is until you actually start doing ortho in your office and you realize that, you have to literally tell your staff how to do each and every little thing, along the way. So POS has an assistance training course. It's really a good course. They will teach them everything that they need to know, to help you and be very, very productive. So that would be something that you would consider. The other thing is, and the software that comes with the program, SmallStream, has a whole series of tutorials. Now, these tutorials are designed to give you the information that you need on everything about SmallStream, but also all kinds of other information. They're usually pretty small. They're 8 to 10 to 12-minute tutorials on almost anything that you need to know as far as SmallStream and POS is concerned. So what I'd like to do is have you, when you are first starting, sit down and kind of write down a sequence of these tutorials and just kind of watch them, one by one. And these tutorials are also very, very good for your staff. So if you want your staff to learn something and to be very, very helpful, you can also have them watch the tutorials as well. Then number 3, it says review the seminar videos. Depending on how you take the course, there's different ways that you can take it. There's the regular, live seminar series. There's the complete virtual series. There is the IAT where you still go to class, but you don't go as often. So there's a lot of different ways to take the seminars. That's something that Progressive can really help you with as far as the types of seminars and the schedule for them. But when you are in a class, regardless of which class it is, you aren't necessarily going to absorb 100% of the information that's presented in the class. So you have videos of all of the previous seminars to watch if you would like. So I kind of throw this in as I would, for instance, just as an example, let's say that you're in a virtual class with me on Wednesday nights. You can also watch the seminar videos of one of the other POS instructors giving a seminar, and you'll hear a little bit different take on the same topic. You'll hear someone talk about it just a little bit different way. We're all saying the same thing, but you might get a little bit different perspective. And the seminar videos are really good for both review and to kind of get a second, take on some of these topics. So they're always there. They're always available for you, once you start. There's something that I pass out, and that's in the SmallStream library, and that's the levels of case difficulty. So this is a multi-page document that will list all of the case types, from the easiest case types to maybe more difficult case types. And it's called the levels of difficulty. It's nice in the beginning when you're first starting because you really don't know what you don't know. And an easy case might seem difficult, or maybe a case that looks difficult is not necessarily that difficult. So you have a document that can help you with these levels of case difficulty. And literally when you're first talking to a patient or maybe starting to work up a patient, you can use this as a reference to decide that, the actual kind of level of difficulty of factor in the case itself. So it's a reference document that I ask people to just have, ready and to look at periodically. And obviously when you're working up patients, you want to have that at the ready. So number 5, this is a whole series of meetings. Now, obviously you're not going to have all of these meetings, but what you want to do is you want to talk about all of these topics in some type of a meeting that you're going to have with your staff. So for example, the first one that's on there says insurance fees and financing. It says care credit, but basically it's financing. So your front desk is not going to know how to necessarily bill ortho insurance. You're going to have a completely different fee schedule that you've never had before. And you're most probably going to use some type of financing option because these cases, are not just, let's say, a single unit that's going to cost somebody, $1,500. These cases are full ortho cases that are going to take 12 to 18 to 24 months. And the patients are going to be paying you, $4,000, $5,000, $6,000. They're not necessarily going to be able to just pay all of that money up front. So financing your office is going to be key. To get more patients early in your ortho career, I would say probably you would want to extend, more financing options to people in your office to make it easier for them to say yes and to, accept the ortho. But your front desk is not going to know anything about this. You have to sit down with them and you have to start discussing, and we'll talk about that this evening. All of these things, such as insurance fees and financing. They're also not going to know anything about scheduling and procedures. They need to know basically orthodontic procedures. They don't need to know the nuances of them, but they need to know the names of them, and they need to know how to schedule you for them. You don't want a procedure that's going to take you 30 minutes to be scheduled for only 15. And you certainly don't want a procedure that you're not even going to need to be in the operatory, where your assistants can do it themselves. And all of a sudden you find yourself having, 20, 30 minutes on the schedule because they think that you need to go in there and do something. So scheduling and procedures and procedure times and, what they're scheduling next for you becomes really important to make sure that you're very, very efficient. Number 3, phone scripts. What I mean by that is not so much scripted, phone, messages, but your front desk and even sometimes your assistants and your hygienists, they're going to be the first ones that people are going to ask questions. So your front desk especially needs to know how to answer all of the basic ortho questions. And there's a list later on, in the seminar that I'll give to you, a partial list. But in other words, when somebody calls, they need to know how to talk to them about ortho, what ortho is, how long it takes, what the cost is, and all of these different, types of questions. Later, I have an entire slide on what I call the ortho benefits checklist. Some people think that you don't have to pre-authorize ortho, but at the end of the day, you probably should. And I'll go over that checklist with you, and you'll see the reasons why. You need to know how to find a case. And what I mean by how to find a case is, obviously you, as the dentist, you're going to be talking to people about ortho. Every new patient that comes in is going to get an ortho exam. But every existing patient in your office, you'd be amazed to see, let's say, how many existing orthodontic cases that you have in your office that you're just not doing. So how to find a case is more how to instruct your staff to help you talk to these patients about ortho, especially your hygienists. Your hygienists really are key because they have the patients in the chair for, let's say 30 to 60 minutes. They need to know how to talk to patients about ortho. They need to ask the question. They need to be able to look at children in a mixed dentition and discern what a deep bite is versus a cross bite versus class 2 versus class 3. They need to know how to help you find cases. And you'd be very, very surprised at how many cases are just kind of just sitting there right in front of you that you don't even know that you have. So it's yet another thing that you need to do or make sure has happened, and that is that your hygienists are trained on how to do this. Your assistants need to know how to help you. Your assistants need to know what a math out plier is. Your assistants need to know what an armamentarium that you're going to need for each procedure. They need to know how to sterilize. They need to know what to set up. They need to know what you need next. They need to know how to talk to a patient about ortho. They need to be able to do certain things for you within the limitations of your, individual state rules and regulations. So I kind of categorize that as assistants' duties. And that's a big one, because if your assistants are really good and they anticipate what you need, and there's a couple of slides on this a little bit later. You'll see that it just really makes your life a lot easier when, and we all kind of know this already, because even in our restorative practices, if you have these good assistants that are always one step ahead of you, they can make your life, so much easier and help you so much. The next one is kits and instruments. There's a whole new array of instruments that you're not used to. And not only do you have to get used to them and kind of know what they are and know how to use them, but your assistants need to know what they are and when you're actually going to need them. So we have setups, typical setups for all the individual appointments that the patient would, let's say, need, that we would give you. If you were taking the seminars, you would get these instrument setups, but your assistants actually need to know how to use them, right? So it's another thing that, if you go back up to number 1 where it says consider sending your assistants to the training course, all of those things as far as assistants duties and instruments and procedure times and sterilization and records and all that, obviously all that is covered in that 3-day class, right? Procedure times, very, very important. Very, very important. You don't want to get scheduled for more time than you need, and you definitely don't want to get scheduled for less time than you need, because it just makes your day run less smooth. So procedure times are key, and there's a way of making sure that you get the exact amount of time that you need for each individual procedure. I'll show you that. It's something that we call the gray form. Records are really important. Records especially for GPs, need to be absolutely the standard of care. So if you've taken the seminar series, you understand what we were talking about, because we really stress quality records. If you haven't taken the course and you're just thinking about joining Progressive, records are very, very important. They're very, very important for diagnosis in general. The better the records, the easier and better you're going to be able to diagnose and treatment plan. But also the standard of care needs to be met with records quality and just records in general. So your assistants need to know how to take really good records, standard of care. And that's something that either you can teach them how to do, or Progressive can teach them how to do. Sterilization in ortho is basically the same, except for the instruments themselves. And the instruments are pretty delicate. A lot of the instruments are delicate. And rust in these instruments is just the kiss of death. So sterilization is kind of an important topic. Each one of these instruments that you're using is more or less about $100 a piece. And you want to take care of them so that they last a long time. Your assistants need to know the best sterilization techniques for ortho instruments, not just a scaler or an explorer or something like that, but I mean ortho instruments. So that's kind of a little specialization, section for ortho itself. Consults, right? You need to know how to get really efficient at a first consult. The very first time that you talk to a patient, there's a way to do that. It's called the gray form. And if you took the course, we would spend quite a bit of time on consults, on how to talk to patients and how to find them. Not so much tonight, but it's something that you do need to discuss with your staff. Supplies and ordering, that's an easy one. It's online, and you go onto SmileStream, and there's a dental supply on SmileStream, and you can order anything you want. But your assistants need to know what they're ordering and how to do it, and how to kind of get online to do that for you. And then sending a case for diagnosis. I put that one in because what I would like to do is eventually get everyone to have a lot of help from their staff. Not just you doing all of this stuff. You doing the mental work, let's say, for the diagnosis and treatment planning, but all of the other stuff, from taking records to maybe placing the records into SmileStream, maybe organizing the records, even placing some points on the set and the model, so that all you have to do is go in and correct and make a little bit of change here and there to something that's already mostly done for you. And it makes your life really, really easy. And then once that's done, your staff can then pick up the ball and send the case in for diagnosis. And you are not stuck with a lot of busy work. Okay? Number 6, Pano and Ceph. Most offices now do have a Pano machine. Most do. Most offices do not have a Ceph arm for their Pano machine. So you have to figure out in the beginning how to get a Ceph because it's standard of care. You have to have a Ceph when you are diagnosing an ortho case. So there's lots of different ways of getting a Ceph. You don't have to go out and purchase a brand new Ceph. You can, you can buy one from a refurbished dealer. There's all kinds of different ways, but it's one of the things that you need to think about if you don't have the Ceph arm or the ability to take a Ceph in your office, how you're going to do that. Cameras, most of us have cameras. If you don't, we would give you ideas on the best cameras. And you don't have to go out and buy a very expensive camera. There are inexpensive cameras that will do a lot of really high quality intraoral pictures. So we will give you a list of those. Number 8, scanner, and I put a question mark on there. You do not have to have a scanner in order to do standard straight wire mechanics. It's my opinion that you should have a scanner if you're doing aligners. If you're still taking old school impressions and sending those into, whatever aligner company that you're using, once you do get an actual intraoral scanner, I personally have an iTero, but once you do get an intraoral scanner of any type, they all work well. They all do the job. The only kind of drawback is if you do want to use Invisalign, you do have to have an iTero. But all the scanners work well. If you're going to be doing aligners along with straight wire, which you should be doing, if you're only doing aligners, that's not good. And if you're only doing straight wire, that's not good either, because you need to do a combination of the two. There's people that would prefer aligners over straight wire. There's people that need straight wire over aligners. There's hybrid cases where you would start with a little bit of straight wire to maybe derotate teeth and then go to an aligner. So you need to know how to do both. And if you're doing aligners, my suggestion is just start saving your pennies because you're going to need a scanner. Okay. You're going to have an inventory, so you need to find space in your office for an inventory, not helter-skelter all over the office, but in one spot where you can get it pretty easy. If for ortho, it's really nice to have a mobile cart, which I will show you a little bit later, so that you can move the mobile cart from op to op and have all the little tiny bits and pieces and springs and coils and rubber bands and chain and all of these little tiny things that we need in ortho, all in one spot, so that you or your assistant does not have to get up every single time you need something. It's all right there for you. Okay? Number 12, practice first and second consults. That goes without saying. The better you get at talking to patients and kind of introducing ortho to them and how to talk about ortho and how much better their occlusion is going to be, and maybe the aesthetics of their smile, that type of thing. The better you get at these consults, you'll find that, you in some offices, depending on the amount of new patients that you have more patients than you can, right? Would almost have to get an associate to kind of handle your ortho department or your restorative so that you can do ortho. And then number 13, don't worry about, because that's for people that are taking the course. And in order to graduate from the course, you do have to take an exam and start a couple of cases, but don't worry about that. Okay, front desk organization, super key, right? Super key. We kind of talked about this already, but if they don't know what they're talking about, everything slows down. From scheduling to billing to, everything slows down. So it kind of starts at the front desk, and this little notation down here, these issues are discussed in detail. That is the other more larger 2-day course that I give, kind of on the same topic. This is basically part of the organization, part of the It's the organization part of a much larger course that I give for 2 days on the business of ortho. So that's what these little notations are when it says, note down. Okay, what do they need to know? Right? And once again, I'm going to send you all these things so you don't have to try to scribble all this stuff down really, really fast. What I want you guys to consider, and what I've done forever, is you really want to set up 2 different types of accounts for your ortho patients, or a different account for your ortho patients. Anything that is regular restorative, you want just in, under, let's say, their name. And if they have an ortho account, you want to make a second account for them I used EagleSoft forever, labeled, let's say, Joe Viviano Ortho. And the ortho account posts only orthodontic charges. That's it. Because you are going to need to keep track of all of these ortho cases that are going to be all over the map as far as when the money's going to come in. Are they going to pay you monthly? Are they going to pay you quarterly? When are they going to pay you? How much are they going to pay you? You need to keep track of all of these things because these cases go on for 12 months, 18 months, or more. And it's very, very easy to lose track. If all of this ortho stuff is buried in a family account under Dentrix or EagleSoft, you're going to have to wade through all of the extra stuff just to find out and make sure that you are on track for the insurance companies paying you, the patients paying you, and make sure that, you're getting paid. I guess that's the easiest way to put it. I mean, literally, right now, Delta Dental will pay you your first installment, basically up front, and then your second one at the end of 12 months. Very, very easy to lose track of that second payment unless you can run a report at the end of every month only on your ortho patients. That's what you want to be able to do. Be able to run a report and literally get only the people that you have in active ortho. That's it. Okay? Your front desk, the 3 big things that they need to know is when, what, and how much time. They need to know when the next appointment is needed. So as these people are coming through your office and they're getting different, the treatment is different, the procedures are different, the amount of time that you need is different, and when you need to see them next is different. We do not see ortho patients every month. That's old school. They used to do that 30 years ago. We do not do that anymore. Ortho, the way that it's done now, the more modern mechanics and the bands, brackets, and wires that we use, we don't even call them monthly visits anymore. We call them adjustments. And the adjustments can be a month if you want. They can be 2 months. They can even be 3 months. And it depends on if it's a mixed dentition case or a phase 2 case. All of these things are different. So these appointment intervals or adjustments are never monthly, and she needs to know exactly when the next one is. Otherwise, they will appoint that patient next month. If you didn't tell them, that's what they would do. And definitely you do not need to see these people on a monthly basis unless there's something that you specifically want to do at, let's say, 4 weeks. The next thing they need to know is what the appointment is actually for. Because once they know what the appointment is actually for, generally they know how much time you're going to need. It's not always the case, but generally they would know based on the procedure. So kind of what to do next and how much time you're going to need is kind of goes together. However, the better your assistants are and the better trained your assistants are, the more that they can do. That means that the amount of time that you need, that she needs to put on your schedule, can probably be a little bit less. And depending on the state and the state boards and what they can and can't do, your assistants, if they're utilized to the max, can really help you out, and they can do the bulk of work. And you can, be doing other things, even to the point of going into your office and getting some diagnosis time. Right? So there is a way to keep track of this, and it's called the gray form. So this is just one page of the gray form. And you can see down here at the bottom, for me, I was old school. You know, I graduated in 1983, and I never went paperless. So I always had physical charts. So I always used a physical gray form. So I wrote down everything that I did. I know that a lot of more modern offices are paperless. It's just the same exact thing. You can make a template in in EagleSoft. You can make a template in Denver, whatever you're using, and do exactly the same thing. But this is what you need to do, and this is the stuff that you need to know when the patient comes in. So the way that the gray form works is, don't worry about this upper stuff. It's mostly down here in the lower that's really going to help you out. So it's got a running monthly total here. So from month 0 all the way to the very end of the treatment. The date that you're actually doing the procedure. Then each time the patient comes in, you're going to actually grade their hygiene. I usually do A through F on their hygiene. We never want a patient to kind of fall back on their hygiene, because once they do, they tend to stay that way, during treatment. What arch wire they have on the upper and the lower arch. What you did that day, and probably the most important thing is what you're going to do at the next visit. So as a case is proceeding, what you would do is just fill this out and kind of keep it going as a running total. So what it might look like after time would be something like this. So you would have a running total of the months. You would have all the dates that you did the procedures, what wire the patient is in, what you did that day, including everything from hygiene instruction to another pano, to X-rays that you took, to everything. And then over here on the far right-hand corner, or right-hand side where it says next visit, this is the way that I've always done it. It works for me. So I would introduce it to you as, a possibility, and then you could critique it and do what you would, any way that you would want. But what I used to do was I would put when I needed the next visit, in other words, 1 week, 2 weeks, 2 months, whatever. Then I would put what we're going to be doing. And then I would put how much time I needed and how much time, let's say, the assistant needed. Actually, this is wrong. That would be 60 for the assistant. So the first number would be me, okay, and the second number would be the assistant. So if this chart walked up to the front desk, your front desk would know immediately everything from what was done, what wire they're in, what needs to be done next, how much time you're going to need, how much time you're going to need, how much time the assistant's going to need, and there will be absolutely no question. What happens if everybody is not on the same page is it all falls back on you yourself. So for example, if you didn't put down when the next appointment was, what you were going to do, and how much time you needed, they would have to ask you every single time. So when you get up from the operatory, you would just tell your assistant, hey, need them back in a month. We're going to cement some bands, and it's only going to take them 10 minutes. And then they know exactly what's going on, and they can bring the patient to the front desk, and everything can be finalized, and you don't have to worry about it. So this is called the gray form. This is a way to keep track on paper. You can make a template that works exactly the same way for your office systems like EagleSoft, if you would like. Okay. So every case basically follows the same pattern, and we talk about this in the beginning of the seminars. But every case has to start with what we would call a first consult. That's where you talk to the patient for the very first time. The first consult really is a discussion between you and the patient, and getting some preliminary information and getting them interested enough to actually take records. You can't really do a proper diagnosis and treatment plan unless you have the records. So the first consult is the discussion, the very first time that you bring up the point for ortho for the patients, which gets them interested enough for you to be able to take the records, which are photos and SEP and pano and study models, scans, That obviously leads to the small screen workup, the computer workup, which is the diagnosis, and then you would choose a treatment plan. Once you do that, you would have the patient back for a second consult, very quick, and you might even start the case on that second consult. So the second consult would be to finalize financing, to have the patient sign the informed consent, and to do things like that, and to tell them, give them any details that you weren't able, let's say, to give them at the first consult. And then the rest of it is just, doing the mechanics of the case. So coordinating these appointments, actually coordinating all these appointments is important, right? So kind of sort of the way that it works, is something like this. You do your first ortho consult, which is, you can also call it a workup, do your consultation workup. You would want to send in for pre-authorization at that point. If the patient's interested enough, then you definitely want to pre-authorize the case. You absolutely need to talk about the financials of ortho, because even if you didn't, the patients are typically going to ask you that question. One of the questions is going to be, hey, doc, how much is this going to cost me if I do decide to, move through with aligners or straight wire or whatever? How much is going to be, my out-of-pocket expense? So all of this preliminary financial information should be discussed right then. Your front desk should already have looked into their ortho insurance every single time, just like the restorative, part of their ortho or their insurance. And so when they go back up to the front desk, if they're interested, your front desk already knows what their insurance probably will pay. Not what it will pay, but probably will pay, because the pre-authorization is going to be the key. At the second consult, after they've taken records and you've done your diagnosis and you have them back, it's always best to have had the pre-authorization back, because that really allows you to absolutely finalize the financial arrangements. And I'm going to show you a slide or two coming up here on literally a list of over 24 things that the insurance company can use to not pay you the entire amount, or sometimes not even pay you the amount. But at the second ortho consult, if the patient is worried about the financial part of it, you really want to make absolutely sure that they know exactly how much they're going to pay, you do have to have that pre-auth back. A lot of patients understand that, maybe their insurance isn't going to pay as much, or, there's going to be a little bit of difference here and there. They're going to do it anyway. It becomes kind of a moot point. But if there are people that do want to know exactly what their patient part is going to be, you got to have that piece of paper in your hand, the pre-auth back. So when you're doing these appointments, these scheduling appointments, especially in the beginning, first consult, records, second consult, what you want to do is, and even when you start the case, what you want to do is schedule these appointments in advance, because they're going to be on a schedule. You would learn this schedule in the seminar series, when the spacers are put in, if you're going to be using bands. You don't necessarily have to use bands, but when the spacer is going to put in, how long it's going to take, before you size, when you order, how you order, when you cement, and the progression of how it goes. In the beginning, there's a big flurry of activity, and then after that, once you get going in a case, that's where an appointment every 2 or sometimes even every 3 months comes in. But in the beginning, you do come in quite often. My opinion is you should pre-appoint all of these, and just make sure that if someone misses one of these appointments, you have to go back and you're going to change not just one, but multiple. Especially in a busy office, because you don't want to just be fitting these people in. You want to actually take some time so that you can, provide some quality service, let's say, not just kind of squeezing and fitting these people in. My opinion on hygiene for ortho patients is I like to have them in 3 times. So this is going to be a work in progress for you. Most insurances will only pay for, hygiene visits twice a year. So one of the three is going to be, if they do have 3 in 1 year, one of them is going to be out-of-pocket expense. So I like my front desk to talk to the patients about, or even the assistants, to talk to the patients about how important it is that we're going to need to keep the teeth and the underlying, perio in really, really good condition while you have these, bands, brackets, and wires on your teeth. And it's really nice to have 3 cleanings, 3 prophies, 3 hygiene visits per year. It's not going to, you're not going to get everybody to do it, but if you talk about it in the beginning and they understand how important you feel it is to, keep things hygiene-wise on the up and up, typically it's not a big deal, and they will do it. And it makes your life a lot easier as well, because working on someone that, and if you're just thinking about adding ortho to your office and you actually never done it, it's so much nicer to work on patients that actually have good hygiene rather than poor hygiene. It makes it nice for you. Okay, insurance issues. Okay. So really, I would say it's mandatory to have the pre-authorization back prior to start. If the patient is not worried about finances, then all of this is off. But most people are, I wouldn't say worried about finances, but most people are definitely wanting to know exactly how much their patient portion is going to be. So there are all kinds of ways that the insurance company for ortho can get out of paying you. And some of them, and I have another sheet that's coming up right here, it's called the Ortho Benefits Checklist that we'll go over. But I mean, some of these are, age limits to even kids that, it says, age limit usually 19 unless you're a student. But I mean, I have seen insurance companies that would say, unless you started the phase 2, the actual phase 2 treatment literally, I think I had one a couple years ago that said by 12 years old, they're not going to pay for it. So there's a lot of limitations when it comes to, ortho. Is it the employee owned? Is it plus the dependents? Are there any benefits that have already been used? We'll talk about that in a second. Lots of other potential, exclusions. So what you need to do is you need to use something like this. And this is one of those PDF files that I will give you along with the gray form so that you don't have to write any of this down. But if you simply have your front desk take out this paper, call the insurance company and ask these questions, you will almost be guaranteed that you know exactly what their insurance will pay and what they won't pay, even before you have the actual pre-authorization back. So the way that this works is, in general, eligibility, right? Who's eligible? Is it just a subscriber? Is it the spouse? And if you're a dependent, to what age? So these are questions. These are questions that your front desk will be on the phone asking the insurance company. It only takes a few minutes to do, and it'll save you a lot of headaches later on. Is there a waiting period? We've gotten bit by waiting period, for Crown and Bridge, in the past. So for ortho, it's the same way. What type of plan is it, right? Is it a traditional plan? Is it a PPO? Is it an HMO? What is it? Are you in network or are you out of network? If you're in network, how much are they going to pay you? If you're out of network, how much are they going to pay you? Is there an annual ortho max, which almost always there is? I'm sorry, not an annual. Is there a lifetime ortho maximum? Ortho insurance is almost exclusively a lifetime max. If the patient has the same insurance company in the same plan, and they use their ortho, in 2022, that's it. They do not get any more for their lifetime for that insurance. So mostly lifetime. But every once in a while, you'll have an annual. And if you do, it's great because, the patient is going to get more money and the likelihood of their actually, going ahead with the ortho is much greater. Is there a deductible? Is there an annual deductible? Is there a deductible if I'm in or out of network? Has the patient had any claims against the lifetime max in the past? So this is where a lot of GPs get bit because, you have a phase 2 that comes into the office, let's say a 12 or 11, 12, 13-year-old, and you are going to do a phase 2, full banding bracketing. But they had gone to the pedodontist, when they were 8 or 9, and he had put a rabbit valve expander or some type of quad helix or something. He had done something and billed their ortho insurance. So they come in and they think that they have their full ortho max. They don't, because the pedodontist, or let's say another GP, 5, 6, 7 years before, used up their entire orthodontic claim, lifetime maximum. So you tell the patient that they have $1,000 or $1,500 of insurance, and they don't, and then you're in trouble, because the chances of the patient, believing you after that when you tell them something, or you are not going to go back to the patient and say, oh, by the way, you owe me another $1,000 because I made a mistake. You're not going to do that. What you're going to do is you're just going to accept the fact that you're going to get $1,000 or $1,500 less for that case. So you don't want to do that. You want the patient to know, and you want to know right up front. Is there a work in progress exclusion? So if somebody comes into your office that is already in braces, the insurance company is not going to necessarily, the new insurance company is not necessarily going to, pay you. So you have to find out about all of those types of exclusions. You need to know when they're going to pay you. Are the payments automatic? Do you have to bill the insurance company to get the money, or are they going to be automatic? Are they going to pay you monthly? Are they going to pay you quarterly? Are they going to pay you yearly? When are they going to pay you? You have to keep track. This is why making a separate ortho account for your ortho patients and then running a report at the end of the month is very, very important. And then are records paid out of orthodontic maximum, or maybe even extractions? Most of the time, anything associated with ortho, from the initial records through the treatment, including retainers, is all included in their ortho max. In other words, you cannot bill for records and then bill the full amount for ortho and then bill them for their retainers. You can't do that. If the insurance company says that they're going to pay you this amount of money and this is all you can charge, that's it. You cannot charge them any more. So you got to be careful about that, because if you nickel and dime them and charge them for retainers and then charge them for records and charge them for this and charge them for that, it can be considered fraud. So you got to be careful. And then usually there's no documentation required on an initial claim form. You just basically have to tell the insurance that it's for ortho, and they're going to accept the fact that you are going to be doing ortho. If you don't, and you bill and accept money for it, and you actually don't do it, that's fraud. And if you ever get caught, you're in trouble. So normally they don't ask for any documentation. Sometimes, like state-sponsored programs and things of that nature, Medicaid, those types of things, they do. And if they do, you do have to have the records, and that's where the record standard of care comes in to be very, very handy. So this is the ortho benefits checklist. If your front desk or your financial person gets on the phone with the ortho company, it takes them 2 minutes to ask all of these questions, and you'll have a much, much better idea even before you get the actual pre-op back exactly where you stand. Okay? This is a way that my front desk developed in my office. I will send you a PDF file on this as well to keep track. And if you notice, this is just an Avery kind of peel and stick label system. So each one of these things is a little kind of individual sticker. And what she used to do is go ahead and stick this onto the chart, and she would have a really good idea of the insurance, who's prime, who's dual, what the max is, are they automatically going to pay, what the down payment is, what the monthly is. And all she had to do was just look right there at that little label, and she could tell from patient to patient to patient kind of where she stood with that. She would still have to run the report at the end of the month to make sure that everything was billed properly and we were receiving payment. But this was a really good way of kind of taking a snapshot. for each individual patient. Okay. So it's an Avery peel and stick. I'll send you the PDF file on that. With insurances, if a new insurance becomes available during the time that you are in ortho, so let's just say, for example, you started a case 6 months ago. Now the patient's parents, let's say, or maybe even the patient, has gotten a new job with a different company with a different dental insurance. That does not mean at all that new insurance is going to pay 100% of that for that ortho. There's all kinds of exclusions that and reasons why they come up with, and they call it, a treatment in progress exclusion or something like that. And you kind of have to read the fine print. So just because a patient gets a new ortho maximum does not necessarily mean that they're going to have that maximum amount. Once again, the ortho benefits checklist is very, very important when it comes time to, figuring out all of those details. Now this is something that I used to do, and every office is going to be a little bit different. In the beginning, I did offer more financing to my patients, but now I don't carry nearly the amount of money that I used to. I will finance somebody for about 12 months. However, in my office, see, I get another. I have a slide for you coming up, but I'll tell you now. In my office, what I do is this. If it's straight wire case, the patient pays $1,000 down, and then I accept their insurance, usually $1,000, $1,500, sometimes $2,000, and then I'll finance their portion after they pay $1,000 down, and I get their insurance. I will finance their portion over 12 months. If it's an Invisalign case, it's $1,500 down plus their insurance, and then I'll finance the rest over 12 months. That's how I do it in my office. I will give a cash discount. If somebody wants to pay me cash up front, I will give them a 5% discount. And works out. People still feel like they're getting a decent option, if they can finance over a year their patient portion after putting a down payment. And this is where you are going to have to decide on your own, in your own office, what works for you. But there's a slide that's coming up that basically describes just what I just said to you. But you will, in your own office, decide how much money you want down, how long you want to carry these people. I would say this. I would not offer financing terms any more than a year, because there's going to be a lot of cases that are going to be done sooner than you think. If it's a very, very easy case, you might be done close to a year. And if you're financing 18 months or 2 years, the patient's not going to have paid you their final installment by the time the case is done. And you don't want that to happen, because then that puts you in a predicament where you have to decide whether you keep the patient in ortho just because they haven't paid you yet, or take the braces off, give them the retainers, and finish everything, and then expect them to continue paying you even after you've completely finished. Okay, well, we're still on front desk. So maybe some of the typical patient calls, / questions that they will get, and that you have to sit down with one of those meetings that I was talking to you about, was patients are going to most definitely ask you about the cost, including their insurance and how their insurance benefits fit in. They're going to ask you time. How long do I have to wear braces? Well, because they're going to consider, 24 plus months. Actually, nowadays, most cases are finished, in 18 months, unless it's just a case that has a lot of mechanics and a lot of things to do. Could be longer than that, but most are 18 months, maybe 24 at the outside. They're going to ask you about payment plans. So insurance / payment plans / financing is going to be important. They're going to think that ortho hurts or is very painful. So they're going to ask you, hey, does it hurt? And, what can I take for pain? If I do have any, what can I eat? Do I have any food restrictions? Do you accept my insurance? That brings up all the insurance questions again. What happens if I have a bracket off? What happens if something comes off? What happens if I have a wire poking? And all kinds of questions that your front desk is going to be asked that they need to know how to answer without bothering you and asking you. So this is one of the meetings that you're going to have, that you should have, to discuss all of these things and how they're going to handle it. How about when we start talking about scheduling, or time management? I get asked this question: what about putting all your ortho patients on an ortho day? Just kind of picking ortho day. Well, there's pros and cons to having an ortho day. First of all, it is really enjoyable. It is really efficient, and I can tell you that from firsthand experience, because that's all I do now on 2 days a week. I just do an ortho day. If you are doing an ortho day as a GP, what I would suggest is that you always include at least a records and especially a band and bond appointment, because that's going to be basically going to be your production. Because people are going to come in for visits and reties and wire progression and things, and it's not going to be a billable or chargeable visit. Your income is like starts. So you need case starts in order to be productive and make money in ortho. So if you're going to have an ortho day, you're going to want to put at least one case start on there, because that production is going to be, somewhere between, let's say, a Delta PPO fee of $3,800, or, in my case, I was Delta Premier only, so my fee was always $5,800. So an ortho day, typically can be somewhere in the neighborhood of normally 6 to 10K in production, but actually a lot more if you handle it correctly. And I have a slide coming up on that. The downside of it is, do you have enough instruments, right? Do you have enough setups? Do you have enough instruments to see patient after patient after patient? Most of the time in the beginning, you do not. So you have to develop that armamentarium with enough instruments so that while you're seeing, 2 patients at the same time in 2 different operatories, some of your instruments are already in sterilization and you're still using some. So that's an issue. Okay? Yeah, one of the other issues is it really possible to schedule all of your ortho patients on the same day? Ortho patients, kind of are all over the map as far as, when they come in. People come in before work, The kids you won't see during the day much, unless it's let's say a holiday or they're on vacation. And then all of a sudden, all the kids will start coming in, let's say 2:30, 3 o'clock in the afternoon, when they get off school and mom, brings them over to the office. So if you're trying to pigeonhole all of your people on an ortho day, a Monday or a Tuesday or a Wednesday, it might not fit the schedule for some people. And you might lose patients or lose cases because of that. So kind of keep that in mind. And the last thing down below is do you have enough patients to fill a day? You can go through a lot of ortho in a day if you're very, very productive, and that's all you're doing. So do you have enough patients to actually fill the day, right? When you get your greatest efficiency is when your assistants are really, really well trained. And you will, we all feel this sometimes when we lose, let's say, a really good assistant, and all of a sudden, you're working, let's say, with a new assistant that you're having to train and is not as proficient. You really, really feel it. Ortho is the same way. One of the reasons why orthodontists can be so efficient at what they do is because they have a whole staff of very highly trained assistants that know what they're doing. And oftentimes the orthodontist just kind of walks around and tells the assistants what to do. So a bunch of, a lot of people, in a big open bay situation on multiple chairs with multiple assistants, and the orthodontist can literally walk around and tell the assistants, hey, let's change the wire today, or hey, let's add headgear today, or hey, let's, place some coils here today. And then they move on to the next patient, and they don't really even have to sit down. So that's eventually the way we want you to approach it yourself if you can, making your life a lot easier. So I made this up, quite a long time ago. It's fairly old now, and I didn't put any numbers on it, just for that reason. But this is what I did, for all of basically my career. I had a 5-operatory office, but I really only worked out of 3. I had the 2 hygienists that were working out of the other ops. So I worked out of 3 ops with 2 assistants. And I will send you this so that you will have an idea of how it might work for you. But I just did, let's say a typical ortho day with 3 ops, 2 hygienists, and myself. And during this ortho day, I didn't put a number down here on purpose, but I will tell you, this ortho day right here was 16,000. And that was I think the last time I figured this out was maybe 5 or 6 years ago. So now it's probably 17, 18,000. So this ortho day right here, the production value for this day was about 18,000, right? Which, as far as I'm concerned, is great. I mean, if I made 18,000 a day, it'd be fantastic, every day, which obviously I don't. So I will send you this as well. So you'll at least have a template, just to kind of get a feel for how it flows and where one assistant might be versus you versus the other assistant, and how the day could flow for you. Procedure times. Procedure times will decrease with repetition and your skill level. So in the beginning, when you first start to do this, your procedure times will be longer. There is no question about it. So what I did is I made up this little sheet, this little cheat sheet for you guys. And this is not exact. It's not rocket science in here, but what it does is it kind of gives you an indication of the fact that in the beginning, you will definitely be a little bit slower. And number 2, you will probably be doing a lot of this stuff yourself before you allow your assistants to really dive in and do it themselves. And before your assistants are really trained, you will be doing some of this. So you got to be aware that the procedure times, the amount of time that it's going to take you to do this, is going to be longer in the beginning. So give yourself more time in the beginning when you first start doing this, okay? And it's another one of these things that I will, give you guys. Okay. The modern wire progression. If you guys remember earlier on, I said that you do not see these people, normal orthodontic patients, every month. That's not the way that it's done. The more modern wire progression that we have is called adjustments. They're not on a monthly basis. And the wire progression that Progressive uses, and is very, very common in straight wire, is this one right here. Something like this. This is not set in stone, but this is very, very common. You would start with what we call a rounded nai-tai wire, and you would stay in that wire for multiple months, typically about 2 months. Then you would progress to a rectangular nai-tai wire, which adds torque into the system, and you would stay in that wire without needing to change it, just that wire, for somewhere in between, let's say, 3 and 6 months. So during that first, let's say 6, 7, 8, 9 months, you're only seeing the patient, let's say 3, 4 times. You're not seeing them in 9 months. You're not seeing the patient 9 times. Let's put it that way. The third wire that you would use is a stainless steel. It's a stiff wire. It's a 1925. It's the biggest that you're going to use. And that one you're going to stay in somewhere between 6 and 8 months, sometimes longer. And that's your mechanics wire. You're going to finish all your mechanics in that wire. So you could stay in this one for a very short amount of time if the case is easy, or you could stay in that wire for a longer period of time if the case is difficult. So it's kind of open-ended on that. And then the last wire, you would double back again to another 1825, and that's your finishing wire. So you're going to make some finishing bends in that wire, and you're going to stay in that wire until the case is completely done. So this is just an example of a standard wire progression and a more modern wire progression. And then this is an example of the timing of one of those cases in a very simple non-extraction case. Okay? So what you would do, typically, you would say, okay, well, I'm going to start with that around nighttime, and I'm going to stay in it for a couple months, and I'm just going to see the patient one time. So the time between your visits is 2 months. Then with the next wire, right, I'm going to stay in it between, 2 and 8, 3 and 8. I'm going to see that patient 3 times, and I'm going to see the patient every 2 months. Then the 1925 and the 1825, you can see you're not seeing the patient every month. So at the end of 18 months, if this case were a pretty simple non-extraction case that took 18 months, you would basically have only 11 adjustment visits, not 18. So a lot of time saving, when you really get to the point where you're efficient at it, and your front desk knows how to schedule. Okay? I know I'm going pretty fast, but I'm doing that on purpose because I don't want to keep you guys here all night. But if you do have any questions, please, put them in the chat, because if you do want to stay afterwards, I'll be happy to answer them for you. But I am going pretty fast, so I apologize.
Dr. Viviano, we do have a question in the chat.
Okay, go. I have a lot of questions in the chat. I will answer all those questions after I'm done. Okay. I will go through each and every one because I can stay here forever.
Okay, sounds good.
Yeah. Okay. Another question that I get often about how are you going to set your fees? You don't have an ortho fee schedule right now. You need an ortho fee schedule. All right. This is something that is definitely going to be kind of up to you in terms of how your office works. I only had 2 fee schedules. I had a fee for service schedule and I had a Delta Premier schedule. That was it. So I had only 2. I understand now the way that it works for a lot of dentists is you have just multiple fee schedules. One thing to remember is whatever fee schedule you have for whatever company, if they tell you that you can only charge X, then you can only charge X. You cannot charge the patient any more than that. If you do, it's fraud. So if let's say if Aetna will pay you $5,000 for a case and Delta will only pay you $3,800, you have to charge your Delta patients $3,800 PPO fee. You cannot charge them anymore. So just be aware of that. So how do you set your fees? Well, you really have to find out what the local fee schedule is in your area. And you can do that in a multitude of ways. You can try to shop around as if you were a patient and have one of your assistants call from their cell phone or their house phone. You can ask some of your colleagues. Everybody knows that, they're orthodontists. Everybody has patients that have either gone through ortho that they know or kids that are in ortho, and you can ask, these patients. My fee was always $1,500 comprehensive and then half for my phase 1 fee. There's a reason why I did that, and that is kind of at the simplest level. If you want to charge more for cases that you feel are more difficult versus less for cases that you feel are less difficult, that's fine. You can do that. There's no problem with that. The only problem that I find that I had with it years ago was if you do that, then nobody in your office is ever going to be able to answer the question, how much does it cost me if I want ortho in this office? The only person that can answer that question will be you, because you are the one that is setting fees at different levels based on your perception of difficulty. So every single case is going to be a new deal. And your front desk is going to have to come to you every single time and say, Doc, what's my charge in this case? And then you could possibly, and I have heard that, this has happened. It's never happened to me because I haven't done it. If you get a referral from a patient and you charge that referral different fee than you charged for the patient that referred that patient, they know each other, one referred the other, and you charge them two different fees, you have to explain to those people why you charge them two different fees. So for me, I just make it easy. My phase 1 fee is 1/2 of my full treatment fee. So everyone in my office always knew exactly how much an ortho case cost. Okay. So the other part of this is kind of at the bottom of the page, and that is, you really don't want to, deep discount your fees. You really don't want to do that, because what's going to happen is, do you really want to be known as that guy or that girl in town that is like the cheapest and is undercutting everybody? And do you want the patients that are absolutely positively shopping for the lowest price? Probably not. You definitely don't want to steal patients from other offices. You definitely don't want to do that. If you undercut, your fees by $1,000, $1,500 on every case, then you're going to get people that, literally will, stop going to another office and come over to your office just because of the fee. You don't want to do that. The reputation is just not going to be good when you do it. So my opinion is for you to just find kind of the prevailing fee in your area and then charge a few $100s less. Now, this is the prevailing ortho fee. So basically, you're giving the patient what could be considered a GP discount because you're a general practitioner and not a specialist. And it really places you at the same level as the orthodontist, but yet your treatment is still a few $100 to $300 less than theirs. So you're still in the ballpark. You're still making a really good amount per case, but yet you're still not charging as much as the orthodontist. If you want to charge as much as the orthodontist, or maybe even more, that is absolutely fine as well. It's just that you won't get as many patients. So it's up to you. If you want as many patients as you can get at a really good return, let's say, then this is what I would do. This is what I would consider doing. Okay. Starting. So I'll also give you, this is a little bit old now, but I'll give you a list of all the procedure codes and what they are, and then what my 2 fee schedules were. Remember, I just said I only had 2 fee schedules, fee for service and Delta Premier. And this is a little bit old now, so take that with a grain of salt, but at least it will give you an idea on kind of where to start and how the procedures might be, how you can go about setting your fees, let's say in your office, just to give you a general idea. I would suggest that everybody get the CDT 23. These pages were taken directly from the CDT 23 ortho pages. They're different every year. They're a little bit different. They took away the limited treatment, primary dentition. Well, they took away interceptive in the primary dentition. So anyway, I would get the CDT 23 codebook, and there's only 3 pages. They start on page 76. This is where you would go. These are the codes that you would put in your fee schedule, along with some of these other ones that I won't go into now, but they're kind of sort of associated with ortho procedures as well, like gingivectomies, cosmetic gingivectomies, and stuff like that. Here is an example of an ADA claim form. The ADA claim form is no different than any other claim form that you would put forward for the patient, except down here in box number 40, where it says, is the treatment for ortho, you must mark yes there. And then if you mark yes, then you fill in 41 and 42, the date that the appliance was actually placed, in other words, when you started, and the amount of months that are remaining. Okay. That's what you have to do. Everything else is the same. The code, what it is, the cost, everything else is the same. But box number 40 is for ortho, specifically for ortho. This, I kind of went through this already as far as payment options. $1,000 for straight wire, $1,500 for aligners, because I use Invisalign and my upfront cost for aligners is quite a bit. Then I bill the insurance, and I'm okay to finance the rest over 12 months. Definitely use credit card on file for your monthly billing. Do not have the patient pay you at the time of visit. Do not have the patient pay you at the time of visit. It's an incentive to not come. Okay? Get their credit card, have it on file, bill it monthly for 12 months. No problems, right? You don't have to ask the patient for money. Patient doesn't have to write you a check. They don't have to bring in any cash when they come in for their visits. And by the way, since they're not necessarily coming in monthly, they're not even going to, be there on a monthly basis to pay you. So do not have the patient pay you at the time of visit. Do not do that. I give a 5% discount for patient payment in full. I give no discounts if it's care credit, because I'm already discounting the case. And I would say to you, as kind of a new dentist / GP orthodontist, I probably would definitely consider longer payment options with less down payment when you first start. But I would qualify it by saying, make sure that someone that you feel like that is actually going to be okay and pay you, because you're going to be finishing a lot of these cases. If you do extend terms, you're going to be finishing a lot of these cases before these people are done, and that's not good. You want the case to be paid in full by the time you are done. So why did I do my phase 1 versus my phase 2 as half-half? And how do I decide if I'm going to start a phase 1 or if I'm going to wait for phase 2, or how am I going to charge am I just going to charge for a phase 1, or do I, charge for phase 2 up front? How do I do this? Well, in my office, it depends on the length of time between the phase 1 and the phase 2. So if there's about a year or more between phases, then what I do is I bill separately for the phase 1, and then when I start the phase 2, I'll bill separately for the phase 2. Okay. The reason why I do that is because you could find yourself in a situation where maybe the case changes a little bit between phase 1 and phase 2. So if you build in total, when you first start the case and it's a phase 1 case, and all of a sudden there's something extra that needs to be done, you're going to need to have to go back to the patient and say, oh, by the way, that full fee that I told you was a total is not a total. You're going to owe me more. An example would be something like an impacted canine. Maybe you didn't feel like the canines were going to be impacted, and one or more actually did become impacted. Now the case is much more difficult, longer, and with additional, mechanics. So I never did it that way because you're not 100% sure how your phase 2 is going to stack up versus your phase 1. Plus inflation, right? Maybe your phase 2 fee is, eventually a year, 2 or 3 down the road going to be more money. And the other thing is, if somebody moves, if you charge up front for everything and you're still in phase 1 and they move, you have to refund their money. You have to refund the amount of money that for phase 2 that you did not complete. And that could be a year or 2 down the road, and all of a sudden you're refunding money to a patient. It just presents, problems that I don't really want to get into. So for those reasons, this is why, and this is how I decided to do either a phase 1 only or a phase 2 and bill everything up front all at once. Question that I get all the time is, are records part of the fee? Well, there's a couple of parts to that. So I would say kind of yes and no. The thing is with ortho insurance, they're going to include the records in the amount of money that they give you regardless. So you can't bill outside of the standard of billing for records like I mentioned before anyway. So yes, they are part of the fee. But if the patient doesn't start, right, and you're not going to bill for ortho because they decided that maybe they kind of didn't want to do it. They thought that they might, and they were kind of on the fence, but they decided not to do it. Well, if you've done all of these records and this work and this workup, are those records part of the fee? Well, then no. You can bill for those records. So if the patient starts treatment, yes, they're included. If the patient doesn't start treatment, then no, you can bill individually for those records. There's a CDT code for a Pano, a SAF, study models, photos. There's a CDT code for all those. You can bill individually. And you can at least get a return on your records. So that's how it works as far as are records part of the fee or not. When it comes time to give the patient retainers at the end of the case, almost always you have to include those in your standard fee. You can't bill outside your standard fee for those retainers. Okay, there's a whole series of, let's see, 7 o'clock. Okay, there's a whole series of slides on how to handle insurance claims. So I'm not going to go through this, individually because I'm going to give you all this stuff, so you'll have it. It's pretty straightforward as far as how what you have to do. For example, how to handle insurance claim. Well, you have to have the correct CDT code, of course. You have to put in the estimated time of treatment. You have to mark box number 40. You have to just do all of those things. And then when you submit it, you don't have to submit any records or anything usually, unless they ask for them. And you get your pre-authorization back, okay? So these slides here have to do with insurance claim submission, how to handle them, how to handle electronic claim submission. Basically, it's the same. Everybody's e-claims are a little bit different. I was a Patterson person, so I had Patterson e-services. So mine were a little bit different. But this is what you have to put in for your electronic claims. An example of what you put in for your electronic claims here. Okay. I get a question about dual coverage, right? In other words, if a patient has dual coverage, do they get their ortho paid in full? And the answer is absolutely, most of the time, not. This is why the insurance benefits checklist is very, very important. Sometimes, believe it or not, if you have dual delta, one of the delta, even though they have ortho, even though the second delta, let's say the spouse has ortho coverage in they work for two different companies, both of them have delta, and both of them have ortho coverage. Believe it or not, sometimes there's an exclusion that says that delta only has to pay one of those claims. Even though the spouse completely, if they were on their own and only had that insurance would pay $1,000, $1,500, whatever the maximum is. It's an exclusion. That's why you have to call on the insurance benefits checklist, because they will try to get around, having to pay as much as they're going to try to get around having to pay. Let's put it that way. So as far as dual coverage is concerned, this is a slide that goes through general rules. Who's the primary? How do you handle dependents? Those types of things. It's pretty self-explanatory when it comes to that. Very, very pretty easy and self-explanatory. All right, kind of general idea on this this kind of topic that we've been on for a while for organization, and especially when it comes time for fees and insurance, and that is just make sure that when you're talking to a patient, they understand that Until you get that piece of paper in your hand that says, we are going to pay this much money for this case, then you really, really don't know for sure. And that's where the checklist comes in. Okay. Sometimes they'll add in even extractions into your orthomaps. Let's say it's a bicuspid extraction case. You think that you can charge for the extractions under a restorative fee. They'll include those in the orthomaps. They shouldn't, but every once in a while you'll find that that's the case. Okay, so you got to call. This is a slide that has to do with that claim form. In other words, mark yes in the box of number 40. Very self-explanatory. Some exclusions, okay, when the patient's plan change. Yeah, there's a lot of different exclusions when a patient changes plans. That's kind of the kiss of death. Insurance companies will use that to their advantage, and they'll say, well, you know what, this is kind of a work in progress, and we don't really have to deal with this, even though they have, if it were a brand new case, they would have to pay their fair share. Because it's a work in progress, they're not necessarily going to pay. You got to be very, very careful when it comes time for that. Exclusions of that type. If it is a new plan, right, and you're going to submit a new claim, you submit it exactly the same way, but you have to write down what the total fee is and all previous EOBs. In other words, how much money the previous insurance company paid you, because the second insurance company, when a plan changes, is not going to give you necessarily the full amount. They're just going to make up the difference. Got to be careful. Will dual coverage pay 100% of contracted amount? Maybe, but there's a lot of exclusions, so you got to be careful there. If you're going to finance, right? I've always just used Care Credit. Now Care Credit is, pretty easy. The patient enrolls themselves, and you get paid pretty fast. So I would suggest that you don't have to use Care Credit because there's a lot of different financing options out there. And there's even in-house financing, which I never really did. And charging interest, I never charged interest. If I said that somebody owed me, let's say $100 a month for 12 months, there was no interest charge on that. You can charge interest if you'd like, if you want, right? I never did. Okay, kind of a little bit of a change of topic here, or change of direction. How about your daily ortho patient flow? In other words, the organization for just on a daily basis, how these patients should flow through your office. This is what I would suggest that you kind of start with. Your assistant should review all the ortho charts in the morning and kind of write notes in the day sheet regarding what you're going to be doing, right? So that all you have to do is look at the day sheet and you can scan down and you know exactly what you're going to be doing and get a really good idea of the day and how much time it's going to take and what you're going to need. When the patient comes in, the first question that your assistant should ask, the very first question is there anything off or loose or broken or poking or painful or anything like that? If they do that, if they ask that question, then the patient will say yes or no. But if there is a loose bracket or something is off, or maybe a band that's bouncing up and down, they'll tell the assistant, and then the assistant can get everything ready for you. When you come in, all you have to do is fix what's needed, and you're not wasting any time. If they don't ask that question when the patient first sits down, the patient's going to wait for you to get in there, and then they're going to look at you and they're going to say, hey, I got this bracket that's a little bit, moving around. And your assistant's not going to have set anything up for you. There's no handpiece, there's no adhesive, there's no nothing. And it's going to take her a few minutes to get everything ready, and it's just a waste of time. So have them ask that question. Make sure that they grade. If somebody's really, really bad, don't see them. Give them a disposable toothbrush. Have them go to the restroom and brush their teeth as many times as it takes until their teeth are clean. Maybe you're pre-scheduled to see the patient, maybe not. If it's just, let's say, a retie or maybe even a simple wire change, you don't even necessarily need to sit down. So that's what the morning review or the morning day sheet will say, and it'll have how much time that you're going to need or spend in each operatory. But what we really want you to do is decide which patients that you actually need to see, really sit down and actually touch, and which ones that the assistants can actually do the work on. We want you to just be able to hopefully kind of step in, say hello, how you doing, this is what we're doing, good job, just kind of small talk a little bit for about a minute, and then just walk out of the operatory and start doing something else. That makes it as efficient as possible for you. Okay. This sheet right here I'll give you as well. It's just one that my front desk made up for me. What's going to happen is these people will, in some ways, kind of get lost as far as where they are in the litany of ortho appointments. In other words, are you seeing these people for just an initial consult? Are you seeing them for records? Have you done the workup because you're doing a second consult? Do they have their spacers? Have you sized or ordered the bands? Did you bracket yet? If you just take this blank sheet and write down the names of the people that are coming in, let's say that week, you will never get lost and you will always know where you stand in the case. Just to give you an example, okay? We've all had the situation where the patient shows up at 8 o'clock in the morning for a crown cementation and the lab has not delivered the crown. Well, what we should have done, obviously, what the staff should have done is the day before made sure that the crown was there, so when the patient showed up at 8 o'clock, there was no issue. If they didn't do that, well, ortho is the same way. If the patient shows up for a bracketing and you don't have the brackets, or the patient shows up for a consultation and you haven't done the diagnosis and the treatment plan yet, you're in trouble. You're scrambling at the last second to get that done. So like this or something like this that you may stop. It's very, very important to keep track of where these patients stand and what you actually need to do for them. Okay? Your inventory. What are you going to do with your inventory? So for ortho, you're going to need an entire new inventory of stuff so that you can actually do ortho. You're going to need pliers. You're going to need rubber bands. You're going to need brackets. You're going to need coils. You're going to need all this stuff. Where are you going to put it? You don't want to put it all over in different places so that every time you need something ortho-wise, you have to visit, 5 different cabinets. You don't want that. You need to put it in one spot so that you can get to it really easily. If you took the course or if you took the assistance training class, they would show you the very, very, very best ways to organize all of this stuff. But basically, you need a place to put your inventory. Okay? You're going to have wire replacement binders that look something like this. You're going to have T-loop and keyhole looped arch wire replacement binders that look something like this. You're going to have bracket replacement wheels that look like this. And this is a slide of what I do for my personal ortho patients in my office. Is I simply have 2 binders, and when I receive something from Progressive, whether it's wires or brackets or any paperwork, I simply put it into a plastic sleeve with the patient's name on it, and I put it into the binder. In this way, all of the patient's materials that you are not using at that particular time, especially let's say wires, are all in one place. So when the patient comes in and you need something for that patient, all you do is you simply go to this binder, you open it up, and everything for that patient is going to be in their little sleeve like this. This is how I do it, to keep track. We have what we call band sizers, so you're going to need to find a place for these things. So what I have in my office, I have one cabinet that I keep all of the ortho supplies in, and then I have a rolling cart that is just like this. It's called a Remo cart. It's a medical grade cart. It comes in all kinds of different configurations. But these carts are actually pretty good size, and they will hold everything that you need on an individual basis. And you just simply roll this cabinet in between operatories, and anything that you need other than, let's say, your bands, brackets, and wires inventory can be found in this cabinet. So you simply pull open a drawer. If you need a coil, or if you need a wire, an extra wire, or you need a cleat, or any of these little rubber band things that we use all the time, it's just right there, and no one has to get up, and it's very, very efficient to have everything in one place. So I have actually a couple of these Remo carts. I have one for my implant stuff, and I had one for ortho, and I would just roll them from op to op, depending on what I was doing. There is an inexpensive option, kind of these little plastic ones like this. But I personally, if you're going to get into it, bite the bullet. These things are not cheap. They cost about $1,000, but you really only need one. Okay? It's called Remo carts, made by Plasdent, Plasdent. Okay. The last couple of things that I want to kind of touch on for you guys is more, I would say, motivation to actually either get going. If you're already doing ortho in your office, but maybe not as efficient as you can, to actually get going and really get going on your ortho and getting good at it and being really productive at it. Or if you're just thinking about adding ortho to your office, what it might be like for you to do that. Okay. So this is a slide, and the next one is basically the same thing. They're just two different ways of showing literally the same thing. And that is, when you introduce ortho to your office, you are going to be introducing more than just ortho. You would be surprised that all of the other procedures that by adding ortho into your office, all the other procedures that kind of tag on and add on. And this is just a list that I made up just to kind of give you an idea of how it would work. And that is, you're going to definitely be doing more cosmetic stuff like whitening and in-house whitening, because these people are in your office because they want to look better. They want their teeth straighter. And at the end, they want them to look really, really nice. So more or less, your kind of cosmetic whitening, that your hygienists are doing or your assistants are doing for you, is going to kind of take off, because you're going to be doing a lot more than that. Your hygiene department will increase a bit, because you're going to be doing a lot more Profis and SRPs, because we're not going to be doing ortho on perio patients unless they're completely cleaned up. That goes down here to number 8. You're going to be doing many more quadrants of scaling and root planing. There's no question about that. You are definitely going to be doing more TMJ related issues, splints, all of those things, because people will come into your office complaining about TMD issues. The reason why they have TMD is because they have a malocclusion of some type. A crossbite, a class 2 div 2, a deep bite. So these TMD patients are also going to be ortho patients. They're kind of joined at the hip. Or an ortho patient's going to come in that has TMD issues, and they're going to be co-joined as well. So you need to know about TMD, TMJ, splint therapy, diagnostic splints. You will be doing more of those as well. If you can, like I've been doing Botox for years for TMD and migraine, you're going to be doing more of that, because you're going to be having these patients come in that not only have TMD issues, but need orthodontics. And, oh, by the way, splints have not done anything, for them, let's say, to alleviate their discomfort. So they might be a Botox patient. So we would teach you how to do Botox as well. Definitely more CMB and rehabs, definitely more, because now you have teeth that are in proper position. Now you can rehab them. Definitely more implants, because you're going to be able to create ideal implant and abutment, spacing. You're going to be doing all kinds of orthodontic surgeries like cuspid retrievals, maybe even some corticotomies if you get into more advanced case types. All of this stuff is outside the ortho charge. All of this is this is extra stuff. you're going to be, if you do some skeletal anchorage, which we will teach you how to do, that is actually more money. It's not included in a standard ortho fee. Your referral base will be increased because people will now know that you're doing ortho and you'll get more and more referrals. You'll definitely get, if you're already doing aligners, you'll definitely get more aligners because people will come to you that, well, actually take that back. You'll get more straight wire cases because people will come to you and want aligners, but they won't be an aligner case. It won't be the ideal case for aligners. So you will get more aligners and more straight wire because one person will want one and one person will want the other. You will do more limited treatments. These are the people that are post-ortho for, a number of years, maybe even when they were a kid. And you're going to be doing limited upper and lower sectional arches, 2 to 2, 3 to 3, that type of thing. That's not cheap. I charge $2,900 for those. Gingivectomies and that type of cosmetic after ortho surgery, recurring retainer replacements, and even retreats. People will come to you that had braces years before, or even your own patients that have had some relapse, and you will get, 5, 10, 15 years down the road, you'll retreat those patients, but maybe segmentally, maybe only sectionally. And all of this is additive onto the ortho. And this is just another slide that kind of, instead of putting a number to it, just kind of shows, how ortho leads, one thing leads to another. And you don't really realize this until you actually start getting into ortho and seeing how productive, it is and how it leads to these other things. So this is the slide that I made years and years ago. And it's based on $5,000 per case. I just kind of picked that. My case fee was $5,800, and I know now that the Delta PPO fee is $3,850. So kind of take this, with these numbers are not, necessarily exact. But the way that this works, for those of you that are either thinking about adding ortho to your office, or for those of you that are already doing ortho but not really doing it a lot, and you're just kind of, doing it as, let's say, a hobby, you have to kind of rethink that, especially in today's economics, because it's really important to be productive now. If you look at the left-hand side of the page here, I just have the columns that says cases per year, 10 through 50, and then what that means as far as the number of cases per month, right? And what the total revenue would be after a year, and 5 years and 10 years. So for example, if you are doing 10 cases a year, that's less than 1 case per month. That's nothing. If you're only doing 10 cases per year, you're really not doing ortho. You're just kind of picking and choosing, your brother-in-law and your nephew and your niece, and you're doing a couple of ortho cases, on them. But even then, if you're getting paid for it, at the end of 1, 5, and 10 years, you've made a significant amount of money. Just by less than 2 cases per month. Really, at the end of 1 year, that still amounts to another 100K in your pocket. And at the end of 10 years, which I can attest goes by pretty fast, right? At my age, I know, it's still $1 million. If you're doing 30 cases per year, now you're doing 2.5 cases per month. Now you will actually feel some ortho patients on your schedule. If you're doing 10 and 20 cases per year, you're not even going to feel those people on your schedule, because they're going to come in so their appointments are going to be so few and far between. Even there, right, which is pretty light, at the end of 5 years, it's still $750,000. And then if you're doing 50 cases per year, right, which is 1 per week, if you're starting 1 new case per week, that's about 50 per year. At the end of 1 year, that's still $250,000 extra that you didn't have before. So if you get decently, efficient at this, and you finally bump yourself up to, let's say, 50, it can be quite productive. And then over here on the right-hand side where it says potential lifetime, I made this one well, in the classes, we have usually have a big mix of people. We have people that, literally are still in dental school. We have students that are taking these classes that are still in dental school. So as soon as they get out of dental school, they're up and running. And then we have people that, retired and got bored and, wanted to do something and took the classes, and now we're practicing, let's say like I do, 1 or 2 days a week is just doing ortho. So we have people that are all over the map as far as the amount of time that they still have to practice in their career. So I made this to kind of give people an idea of how that might work. So for example, if you're doing 30 cases per year, which is not really a lot, it's 2.5 cases per month. At the end of 10 years, you've still 1.5 million. And if you're fresh out of school and you have a long time to practice, you still have a career to practice, and you're only doing 30 cases per year, you're gonna add 5 million to your 401k over and above what it normally would have been. If you're right out of school and you're gonna practice for a significant amount of time, you're in your 20s and you graduated from school, you're gonna practice for 30 years, maybe more. Well, if you bump your cases up to about 50, which is just 1 per week, that's an extra 7.5 million in your 401k. So I made this slide just to kind of give people an idea of the productivity that's actually out there. You can find yourself somewhere, in this mix, just maybe doing it as a hobby and making a little extra, to take a few extra vacations now and then. Or you can do it for real, maybe bump yourself up to 50 cases per more and do it for 10 or 20 years and make significant amount of, money at it. Okay, so this, and I know I went really fast. I have 44 questions in the chat, which I will answer those. I usually don't talk this fast, but I wanted to get you guys in because now it's 7:30 and it's been 2 hours. I'm going to give you guys all of this stuff, including a lot of reference files, so you'll have it. If you have any questions, you can ask me even after I finish these questions that are in the chat. No problem, just email me. If you have any questions for the people at POS, no problem, just email them. This, what I just gave you right now, is just a very small part of a bigger kind of 2-day seminar that I give. It's called Incorporating Ortho, not organization, but Incorporating Ortho. And this right here was maybe about 60, PowerPoint slides. In this 2-day seminar, there's about 400 PowerPoint slides. And it kind of takes you through all of this stuff. This is the syllabus for that 2-day seminar that I give. So if anybody's interested in getting really into the details, and I mean really into the details, for example, one of the things that people really liked that I did for this seminar was I made an ADA claim form for every single possible procedure that you could ever imagine. And I completely filled it out. And so you get a book, that's probably about 2.5 inches thick, 2 inches thick, and it'll have a section and it'll have a claim form that's completely filled out for you already. All you have to do is copy paste and put your patient's name in there. So it's something that I did for this course that just so happened that people really liked because it was kind of a no-brainer for them. So anyway, if you want, just contact me and I'll give you a little bit more information in this. If you are thinking about getting into more detail, I'll have that, or you can contact POS as well. Okay, so there's my 61 slides for you guys. Apologize for going so fast, but I wanted to get it in so I didn't keep you too late. And now what I'm going to do is going to open up the chat box and answer all of those questions. And when we finish with this, if I didn't answer the question and you still have another, please put it in the chat box because we'll just kind of stick here until we get them done. Okay, so from Houston, it says, new to ortho, are you saying that a CEP is required in every case? What about a small relapse case? Yes. there are smaller case types where you're just doing limited ortho, where you wouldn't have to, where you would not have to do a SAF. You know what? I don't like that screen. So the answer to that first question was, if you really have just a very, very tiny, let's say, relapse case, get that out of the way. If you have a relapse case, no, you wouldn't have to have a full SAF or a full workup. You actually wouldn't really consider that orthodontics. You would just consider that just kind of, super limited treatment. You wouldn't be able to bill it out as ortho. So as far as the insurance company is concerned, it would not be considered ortho. So the answer is no, you would not have to have a full SAF. If you're doing regular ortho at all, whether it's a mixed dentition case, a phase 1 or a phase 2, yes, you do. You actually need a SAF. You do need one. Okay.
Dr. Viviano?
Yeah, go ahead, Vera.
Oh, are you looking at the questions? Because I wanted to...
I am. I'm looking at them right now. I'm scrolling through them. So, Dr. Viviano, we have a question. I had a claim come back that said the ortho case was completed too quickly, and therefore insurance can't pay the rest. Have you ever seen this? No, I personally have not seen that. Now, on those slides that I'm going to give you, what it will say is, it will say, go ahead and charge the patient something. In my office, I charge them $1,000 down. Then I accept their insurance. So that's the amount of cash that I get, right up front. Then whatever the patient part is, I will actually finance that over 12 months only. And there's a box, it's box number 42, that's in that ADA claim form, that says how many months is this treatment going to go. And if you put in 12 months, they're going to have to have paid you their amount of money within that 12 months. So you don't put 24 months or 36 months, because all that does is give the insurance company license to spread out the amount of money that they pay you over a really long period of time. You don't want to do that. You want to get paid within 12. I personally have never had an insurance company say that, like the case is done too fast. I don't know what the EOB, that doctor sent in, that you sent in, and what did it say on there that the insurance company said you did it too fast? And what did they mean by too fast? Did they mean 3 months or 6 months? Normal at ortho goes at least 12 months. And that's what I'm telling you guys to put in box number 42 on your ADA claim form. 12 months, then you'll have no problems with the insurance company. Okay, so no, I have not seen that. Okay, fees. What would you charge for relapse cases? I have a ton of cases who would be done in an Express 7 series that can't justify a full $6,000. How do you deal with these cases? So I charge for a relapse case. It depends. And if it's just an anterior relapse case of upper and lower 3 to 3, I charge $3,000. If it's a full relapse case, you're putting all bands and brackets on. How difficult the relapse case is, let's put it that way. Is it a really hard relapse case, or is it just a really easy relapse case? Like Express 7 maybe would do. No, I wouldn't charge the patient a full fee for that. If an Express 7 would do it and it's a relapse case, I would charge them what I charge for my upper and lower 3 to 3, which is $3,000. Right? That's what I would do. So, next question. Is there a difference in fees for aligners and straight wire? And if so, how do you code aligners? Aligners are coded exactly the same way, right? If it's a full treatment case, if it's ortho, it's ortho. So the insurance company doesn't know whether you did aligners or you did straight wire. They don't know that. So an 8080 is an 8080, and regardless of an 8090 is an 8090, regardless. However, some insurance companies, this is why the insurance benefits checklist is important. What you want to do is ask them if they'll actually allow you to charge the patient more for aligners, because aligners cost us significantly more. They know that aligners cost significantly more, and some of the better insurance companies, like some of the Teamsters and some of these higher end, not the Deltas, not the Aetnas, not the Cignas, but some of the trade union insurance companies that have really good benefits will actually allow you to charge more money for aligners. So let's see. Let me see if I answer that with insurance. What other code for aligners? So the code doesn't change, right? And are you allowed amount of 4,000? Can you charge more for aligners? Not necessarily. Once again, you actually have to talk to the insurance company, because you could find yourself in a fraudulent situation thinking that because one insurance company allowed you to charge a little bit more for aligners, that doesn't mean that the next insurance company will. So you have to ask them individually, or you could be committing fraud. Okay, from Dr. Wang, for aligner cases, if Delta only allows us to charge them their contracted fee for those contracts, how do you manage differences? Wait a minute. Delta only allows us to charge them their contracted fee for those contracted with them. How do you manage it? If I think I'm reading that question right, we're stuck. If you're contracted with an insurance company, and it doesn't matter what the insurance company is, and the insurance company says that you can charge $3,000 or $4,000 or $5,700 or $5,300, that's it. You cannot charge any more than that, or you're committing fraud. So just because Invisalign charges me $1,800 instead of $200, like my straight wire from POS cost me, doesn't mean that I can charge the patient more money unless they tell me that I can. Be careful. So I have heard that you can charge an Invisalign upgrade as long as you charge the same fee to your cash patients as well as your insurance patients. Have you heard this? You have to. See, we all want to get around the fact that we're paying so much more money for our aligner cases, right? Unfortunately, the insurance companies have us boxed into a corner. You cannot automatically charge an Invisalign upgrade. You cannot do that. The fine print in these contracts that you guys have signed, these HMO and these PPO and these capitation plans and all these contracts, the fine print, you have to read the fine print. And sometimes they will allow you to do that, and sometimes they will not. It's up to the contract that you sign, and you have to inquire with the insurance company and not do it automatically. Okay. All right. So I think there's no more questions in the chat. There was a lot of hello and nice to see you in there. There wasn't 44 questions, so we're pretty good. But is there any, based on just what we talked about this evening for a couple of hours, the questions that were in there, does anybody else have any, additional questions now that they would like to ask? Since they're not in the chat, you guys can unmute yourself and ask the question if you want, since we pretty much, finished that. But if not, so I'll leave you guys with this. So for all of the people that are already doing ortho, what I tried to impress on you guys, tonight was, maybe a little bit of organization, and getting your office to kind of run more smoothly would go a long, long way to, making your life a lot easier and, more productive. And for those people that maybe are just thinking about, adding ortho to their office, there's more to ortho than, just placing a bracket and putting a wire in and, having the patient wear some rubber bands. There's a lot more to it than that. And if you can make, your life very, very efficient, you'll be very, very happy. Believe me. Because I've talked to, so many, dentists that start and they say, this takes me a little while to do this. And, my staff is, not that, great at helping me. And it's a problem. So it's a problem that needs to be addressed. If you have any questions at all, and there's a couple more in the chat, which I'll see, but if you have any questions at all, they will give you my, in fact, I'll give it to you right now, but they can also give it to you. You can email me directly. If you want to email me directly, you email me at gobike, G-O-B-I-K-E, at sbcglobal.net. So it's gobike at sbcglobal.net. And I didn't come out very bright. So gobike, G-O-B-I-K-E, gobike at sbcglobal.net. Email me directly. I'll get back to you. I'm usually available Wednesdays, Thursdays, Fridays. I've got all kinds of other stuff that I can send you if you have a question that's unrelated to this. If you have any questions for the company regarding seminars, where they're at, how you can take them, the costs, all of that, those guys are there to help you out. And between the two of us, we'll get you answered. Okay.
Dr. Viviano?
Mm-hmm.
So Dr. Levitt just wrote, he wanted to write to you, but he wrote to me, so I posted it. And then several doctors were asking directly about the cost, so we will follow up regarding the traditional ortho aligners. We will send all these doctors emails.
So Progressive gives seminars in various different ways. You can take the traditional seminar series. You can take what's called the IAT, the Internet Assisted Training, where you don't actually have to travel that much. Travel a little bit for the hands-on training. And then you can also take it virtually. There's a class that is given. I give one on Wednesday nights from 5:30 to 8:30 Pacific time. And it's all virtual, right? And when it comes time for the hands-on, let me just give you a little idea of how that might work for you, because it is a question that some doctors have regarding the hands-on. So when it comes time for the hands-on training, what we do is, you're looking at my desktop right now, and what I will do is I will literally show you what's going on, bend wires, put brackets on, do anything with my second webcam here. And then I'll have you show me what you do with your webcam. And we can do the hands-on training literally virtually with this method, with my second webcam. So that's the virtual series that you don't even have to travel at all. You can sit like I am. I'm on my house right now with my whiteboard behind me. You can sit and watch from your home on Wednesday nights Pacific time, 5:30 to 8:30. So there's all kinds of different ways to take it. There's different ways to pay for the series, and I'm not involved in any of that. That would be the company, and they'll give you all the details on that. But if you would like for me to show you maybe details of how that might work for you, or if anybody's interested in the SmallStream software itself and how that might, help you decide to maybe take the series or not, let me know. I'll have a Zoom with you, which I'll take you through all the nuances of SmallStream and answer all your questions with that as well. Okay. Incorporate orthodontic practice. Got it. All right, you guys. Well, maybe I won't take up any more of your time here. But once again, thank you very much for coming in. And if you have any questions at all, just go ahead and email me or email anybody that was there, like Christine, Amalia, Rebecca. They'll answer any of your questions as well.